So welcome to today's webinar, an update on COVID and Down syndrome. Today, we look forward to hearing Down Syndrome Medical Interest Group USA's vaccination position statement and Trisomy 21 Research Society's COVID and Down syndrome survey. My name is Jessime, and I'm with the Matthew Foundation. The Matthew Foundation's mission is to improve the quality of life for people with Down syndrome and developmental disabilities. We are an organization that supports and collaborates with others to advance medical care and research, promote inclusion, and support employment initiatives. And if you're interested in more information, please visit our website at www.thematthewfoundation.org. And before we get started, we'd like to thank Professor Craig Heller and the Stanford Down Syndrome Research Center for your support. The center has focused on basic research to improve learning and memory in individuals with Down syndrome. But it also works to bring together those with experience and interest in many areas that contribute to improving the lives of people and families affected by Down syndrome. We're also helping some faculty at a California university explore the idea of creating a 4-year residential post-secondary education program for people with intellectual and developmental disabilities. The faculty would really like to know if this type of program is important to the Down syndrome and IDD community. So if you could fill out this 2-question survey if you're interested, they would really appreciate it. And you can also find this survey on the Matthew Foundation's activities and events page. And today we're honored to have Dr. Brian Chacoin and Professor Andre Stridham join us. Dr. Chacoin is the medical director of Advocate Medical Group Adult Down Syndrome Center and a DISMIC board member. And Professor Stridham is Professor of Intellectual Disabilities at King's College London and the President of Trisomy 21 Research Society. They will spend about 15 minutes each making their presentation, and then we will follow up. Then we will open up for questions, and you can use the Q&A button to ask questions. We've received a lot of questions already, so we will try to read a mix of questions from the chat and those that we have received by email. And now we'd like to welcome Professor Stridham.
Thank you for the invitation to contribute to this talk today on COVID-19 in people with Down syndrome. And I will be representing the Trisomy 21 Research Society. The Research Society is the first international non-profit scientific organization founded to promote basic and applied research on Down syndrome and to stimulate particularly translational research and apply new scientific knowledge to improve the quality of life for people with Down syndrome. So it's an international organization, and you can see the links to our website and Twitter feed on the screen. So the other thing I should probably say as a conflict of interest, if you want, is that I myself was diagnosed with COVID-19 2 weeks ago, so spent a rather miserable Christmas trying to recover. I'm still a little bit short of breath, so I hope you can hear me okay. But when the initial wave of the pandemic hit us, there were a lot of concern about people with Down syndrome. And the risk to people with Down syndrome because of the additional health issues, for example, diabetes and obesity, that we knew to be an issue in people in the general population when they develop COVID-19. And also the knowledge that viral infections and pneumonia are an important health concern for people with Down syndrome in general, and that people with Down syndrome may have unusual immune systems that could put them at additional risk for infections such as COVID-19. And furthermore, from work that we've done reviewing the literature, it became apparent that when people with Down syndrome develop infections, they are at greater risk for admission to hospital, may have prolonged stay at the hospital, and may require more often intensive support, particularly for respiratory tract infections. So for these reasons, we were quite concerned in the initial stages of the pandemic. And so what we did was to put together an initiative that's focused on an online survey of people with Down syndrome who have been diagnosed with COVID-19. Also worked with stakeholders, including the Matthew Foundation, to consider statements about shielding or confinement of individuals with Down syndrome, and more recently, a statement with regards to vaccinations. We also undertook a number of literature reviews and other research, also supported other research, some of which I will be presenting here today. So what I'll be focusing on is a survey that we conducted, which now has more than 1,000 participants of people, families of people with Down syndrome who had been diagnosed with COVID-19. And in addition to that, we had access to data from a national survey of COVID-19 in hospitals in the UK, in which everyone with Down syndrome were identified. So the national survey collected data from people in the UK who had been admitted, about 60,000 people had been admitted with COVID-19 to hospital. And within that, we were able to identify 100 people with Down syndrome who were admitted to hospital, and were able to then do direct comparisons between them and people from the general population. So that's just a summary of the data that we're going to be talking about. In this case, we're focusing on about 800 cases. As I say, we now have more than 1,000, but this analysis was on 800 cases. 461 were reported by clinicians, 340 by families. In some cases, they were overlap, but we removed the overlaps where possible. 422 were hospitalized. And at the time that people completed the survey, 60% were fully recovered, and sadly 14% have died. And I've mentioned the hospital survey data from the UK. So first of all, what we looked at was symptoms of COVID-19 in people with Down syndrome. So overall, people seem to present in the same way as in the general population, with a fever, cough, shortness of breath. What may be slightly different is that people, particularly children, had more nasal symptoms, so runny nose, sneezing, and but shortness of breath, just like in the general population, was associated with hospital admission. I must say that the symptoms vary. It's not necessarily that the sequence goes fever, cough, shortness of breath, and nasal symptoms. In my case, for example, it started more with a runny nose type and sore throat kind of picture before I started coughing and had fever. So it can vary, I think. So are the symptoms different in people with Down syndrome compared to the general population? So I've already mentioned that it's the main symptoms are the same: fever, cough, shortness of breath. What we found that were more common in people with Down syndrome when they got to hospital, so we're talking here about the hospitalized patients, was that they seem to present more often with altered consciousness or confusion. Usually that means people are more severely ill. And so it may be that people get to hospital a bit later, or that they are more likely to get confused when they are affected by the illness. What was less commonly reported in patients with Down syndrome was joint pain or muscle aches, vomiting and nausea. It may be that patients with Down syndrome are not able to report this clearly themselves, or otherwise that the clinicians are not able to ask or do not know how to ask for these, or do not specifically ask for these symptoms because they are more focused on fever, cough, and shortness of breath. And so next what we did was to look at existing health conditions and what the associations were with existing health conditions and the risk for poor outcome of COVID-19 in people with Down syndrome. And by poor outcome, we mean either hospitalization or mortality, death. So the risk factors that were associated with poorer outcome are here given in, maybe I could use a highlighter, are given here in orange. So that include, just like in the general population, older age. So the older people are, the higher the risk. Obesity, just like in the general population, seem to be a risk factor. Alzheimer's disease and dementia, which is quite common in older adults with Down syndrome, again, increased risk for a poor outcome. Males were at higher risk than females, again, similar to the general population. And it looked like congenital heart defects, whether it was had surgery, treatment or not, was a risk factor for hospitalization, not for mortality, but for hospitalization in people with Down syndrome. Potential risk factors. So this means that risk, where the risks seem to be slightly increased, but not necessarily statistically significantly so. That included reflux, perhaps because it may affect breathing, seizures and epilepsy, certainly in children that seem to be associated with increased rates of hospitalization if they develop COVID-19, obstructive sleep apnea, and chronic lung disease. So anything affecting the lung may be an additional risk factor. Things that did not seem to be associated with increased risk for hospitalization or mortality were the living condition, whether people lived at home or in residential care facilities, whether they had a more severe intellectual disability, whether they had thyroid disorder, or whether they had additional behavioral issues, including autism spectrum disorder. So those things were not associated with more severe outcome. So next we looked at what happens when people with Down syndrome are admitted to hospital with COVID-19. And what we found, and this is comparing to the general population, we're just talking about people who are in hospital now, we found that lung complications were more common in people with Down syndrome, including viral and bacterial pneumonia, and what is called acute respiratory syndrome, so sort of a quite severe sort of respiratory picture. So lung issues seem to be more common in people with Down syndrome with COVID-19 compared to the general population. But things that were as common were heart complications, kidney problems, and blood problems like anemia. And are people with Down syndrome more at risk of dying of COVID-19? So overall, just to explain this graph, these are the proportions of people who died, again, in hospital. We're just talking about people who got so severely ill that they had to be admitted to hospital. These are the data from the general population in the UK, from the US, specifically New York City. That was, they were first to publish this kind of data, and in Spain. And these are the people who've been admitted to hospital in our survey. Brown is males and pink is females in each case. So you can see the same pattern that men, whether they have Down syndrome or not, are at higher risk for dying with COVID-19 than women. But overall, the overall number of deaths or proportion of deaths was similar in people with Down syndrome compared to the general population. Nevertheless, when we drilled down in more detail by comparing people directly in terms of age, it became apparent that if you compared adults with Down syndrome of the same age, then the risk seems to be higher. So here you can see it's the individuals, the adults with Down syndrome, how the risk increases with age compared to the general population. And of course, because there's still a difference in life expectancy in people with Down syndrome compared to the general population, a lot of the deaths in the general population were actually in the very old population, people over the age of 80. And so overall, if you match for age, then the risk in people with Down syndrome are about 3 times the risk in general population. And we estimated that for hospitalized individuals, the risk of mortality in an individual with Down syndrome over the age of 40 was similar to the age of those over the age of 80 in those without Down syndrome. So that gives you an idea of the overall risk. However, very few people in our survey, very few children with Down syndrome have died with COVID-19. Only 4 people that we've identified who've died, children with Down syndrome under the age of 20, and all of them were from countries where perhaps access to medical care is different, such as India and Brazil. And it means that it's very difficult to make any conclusions. In the UK dataset, for example, the hospital dataset, there were no children with Down syndrome who had died of COVID-19, although there were some children in the general population who had died. So just a summary of what we found so far, the take-home messages. So we would say, look out for the same symptoms as in the general population. Some symptoms may indicate worsening illness, and that includes a shortness of breath and change of consciousness or confusion. And among hospitalized patients with COVID-19, lung complications are more frequent. So this is important for clinicians to know, to support breathing and look out for secondary infections in people with Down syndrome if they're admitted to hospital with COVID-19. Comparing people of the same age, gender, and ethnicity, adults with Down syndrome, but maybe at more risk, particularly those over the age of 40, for death compared to patients without Down syndrome. We don't think the risk is the same for children, so very few children with Down syndrome have died. And I've mentioned that in the UK and the US, we have not identified any deaths of children with Down syndrome so far. And finally, based on this data, we would recommend prioritizing vaccination for people with Down syndrome, particularly adults with Down syndrome, alongside older adults in the general population. And very briefly, just highlighting what we could not do. So our data we're not able to say through our data whether people with Down syndrome are more likely to catch the virus. So we can only talk about what happens once they have the virus. And we also were not able to say how many people are asymptomatic, but we know from other clinicians' reports that it's not necessarily that people would be symptomatic when they do when they are infected with the virus. So there may be people who are asymptomatic as well. And we're not sure how best to treat people with COVID-19, but Dr. Chacon may be able to give a little bit more information on that. And finally, I'm not going to go through this, just to make it clear that as with any research, there are some limitations, some study limitations. Thank you.
Thank you very much, Andre. Really have appreciated the opportunity to work with you on this project, and really enjoy working with you. And Jessamy, thank you very much for inviting me to participate, representing the Down Syndrome Medical Interest Group USA position statement on COVID-19 vaccine. I should say right up front, we are giving general recommendations. We cannot specifically prescribe or recommend for any individual, we are not your healthcare provider. So that ultimately, if you have questions, I would encourage you to take additional questions to your specific questions for your individual with Down syndrome or intellectual disability. I'd encourage you to talk with your healthcare provider. So just real quick, I'm the medical director of the Advocate Medical Group Adult Down Syndrome Center, which is in Park Ridge, Illinois, in the United States. That's our clinic up there on the upper right corner. We are in the suburbs of Chicago, and that's what's referred to as the Bean in Millennium Park on the lower left, and then home of the Chicago Cubs there in the middle. And then we are on the campus of the Advocate Lutheran General Hospital, there in the right lower corner. We opened in 1992, and we've seen about 6,000 adolescents and adults with Down syndrome. And in an average year, we see about 2,000 unique individuals for about 7,000 patient encounters roughly. So I'd also like to introduce you to the Down Syndrome Medical Interest Group. We are a group of healthcare professionals from a variety of disciplines who provide care to individuals with Down syndrome and or their families. And we're committed to promoting the optimal healthcare and wellness of individuals with Down syndrome across the lifespan. And as was mentioned, I am on the board of the Down Syndrome Medical Interest Group. So I want to just who contributed to this position statement. So it was a wide variety of Down syndrome medical interest group members, DSMIG members, who are experienced with COVID-19 and people with Down syndrome or intellectual and developmental disabilities, or IDD as I'll refer to it going forward. And so we developed this statement, and then reached out to a number of organizations who have also signed on to the statement in agreement with what we have put forth. So why is this statement important? Personally, we were just getting inundated with questions about, should my son or daughter with Down syndrome or IDD get in a vaccine? So we really tried to pull this together for not only for our to help interest in our own practice, but certainly across the United States and the world for people that are looking at possibly getting the vaccine. So just looking at statistics, and actually when I put the slide together, it was more than 20 million cases in the United States of COVID, and as of this morning, that's about 21.5 million. And when I put the slide together earlier this week, it was 350,000 deaths, and now it's about 365. So clearly a very significant healthcare problem, as I'm sure you're all aware. And unfortunately, people with Down syndrome and other intellectual disabilities have been disproportionately affected by COVID infections, by the COVID pandemic compared to the general population. So, and this is in terms of impact on their daily lives, the reduction in their support systems, and of course, the serious illness from COVID-19 that Dr. Stryden has just discussed. And just in the last week or two, the Centers for Disease Control in the United States included people with Down syndrome as one of the high-risk groups with regards to the effect of COVID-19, potentially causing serious illness, and thus hopefully then we'll move them up the list as far as making the vaccine available to them as we go forward. Dr. Fauci, and so again, the vaccine, looking at the vaccine, Dr. Fauci recently said, who's the director of the National Institute of Allergy and Infectious Disease here in the United States, he said, certainly it's not going to be a pandemic for a lot longer, because I believe the vaccines are going to turn that around. Vaccines will help us. What we've got to do is just hang on and continue to double down on the public health measures. In the meantime, the hand washing, the masks, and the physical distancing. So certainly we think this is true for, or certainly hope that this is true for people with Down syndrome and intellectual disabilities as well, going forward, that the vaccine is going to really turn this around for our community. So in looking at all that, we put this position statement together that we recommend the COVID-19 vaccine for individuals with Down syndrome or other intellectual disabilities who do not have a specific contraindication to the vaccine. This statement is consistent with national and local guidelines for receiving the COVID-19 vaccine. But what we're going to talk about in the next 10 minutes or so are some additional questions and comments with regards to more specifically to the Down syndrome and intellectual disability communities and those individuals and what might be some unique issues there. And again, if you have specific questions on this, we would encourage you to reach out to your healthcare provider for your individual situation. So as you may have heard, this is these vaccines that are becoming available are messenger RNA vaccines, which is a newer kind of technology for vaccines. And they have been approved in the United States by the US Food and Drug Administration, the FDA, via an emergency use authorization, an EUA. And there's presently 2 vaccines available, and one is the Pfizer vaccine, and others the Moderna. These have been studied in clinical trials and met safety and effectiveness requirements. But the EUA refers to that in the event of a public health emergency, which obviously the COVID-19 pandemic qualifies, the FDA can issue these EUAs to allow use of a medical product before they are fully approved. So they have been studied, but not gone through the usual fully approved process. You will see in the next slide that tens of thousands of people were included in the studies, and the overall assessment by those that whose job it is to assess vaccines is that the overall expected benefits will outweigh the potential risks. So you can see from this slide that there were almost 44,000 people that were studied in the Pfizer study, for the Pfizer vaccine, and about 30,000 and the Moderna, with many sites across the US and a wide variety of ethnicities and age ranges. So lots of people were studied. The one downside, unfortunately, to the study, well, before I get to that, so just a little bit more about messenger RNA vaccines. What happens with this technology is that they cause the human cells to make a harmless piece of what's called the spike protein, which is on the COVID-19 virus. And then in response to that, our own immune system develops immunity against the protein. The vaccines do not contain a live virus, and they do not affect or interact with a person's DNA. There's been some concern about whether they will implant into our DNA, and that has not been found to be the case. A downside to the studies, unfortunately, is that people with Down syndrome or other intellectual disabilities were not included in the studies. And unfortunately, this is not different than usual. So really, vaccines, medications, supplements, typically people with Down syndrome or other intellectual disabilities are not studied before they are released for general use. Occasionally, a vaccine or medication or a supplement will be tested specifically in people with Down syndrome or other IDD post-market after it's been released. But to our knowledge, this type of study has not been initiated for people with Down syndrome or other intellectual disabilities at this point, although that would certainly be something that people will be interested in going forward. The other thing is that they were not studied in children. So the Pfizer vaccine is available for people 16 years and older, and the Moderna here in the States is available for 18 years and older. And just a quick look at the two vaccines. I'll just highlight the number of shots. It's both of them at this point are two. It's a 2-shot series with the Pfizer being 21 days apart and the Moderna being 28. And again, you see the ages there. Storage is somewhat of an issue, particularly for the Pfizer, because of the need for lower temperatures for storage. So that is somewhat of an issue, but again, that is being worked out with the distribution plans. And as far as side effects, the typical side effects would be a pain or soreness in the arms, some swelling, some redness. Sometimes you get chills or fatigue or headache, muscle aches, fever. And this is not dissimilar from other vaccines. And it's just normal signs that your body is building protection. I am aware now of about 600 or so people with intellectual disabilities that have had the vaccine in just the recent days with very limited, significant side effects and no real concerning side effects. And the most concerning side effect would be allergy issues, which would then actually, those are the folks that should not get the vaccine. And let me explain that. So anyone that has a severe allergic reaction, which is called anaphylaxis in response to the first dose, should not get the second dose. So what is anaphylaxis? That would include difficulty breathing, your blood pressure dropping, and in response to the blood pressure dropping, you would become dizzy, perhaps, and then other serious symptoms. And that's typically treated with an injection of epinephrine or an EpiPen at the time of the reaction. And this is something that typically occurs within the first several minutes after getting the injection. And so people that have that reaction are not recommended to have the second dose. And really, I'm just across the country that I'm aware of, there's really just been a handful of people that have had this kind of reaction. And of the 600 or so people that I know with intellectual disabilities that have had it, I'm not aware of any of those folks that had this reaction so far. And then if a person has a severe allergic reaction or anaphylaxis to a different injectable therapy, either a medication or a vaccine, the CDC recommends considering potential deferral of the vaccine. So they're not saying definitely don't get it. They're saying, have a conversation with your healthcare provider and decide on your risk benefits and what would be appropriate for you. For anyone that gets the injection, it's recommended for 15 to 30 minutes being observed. So when I got my first shot, we just had to sit there, wait for 30 minutes while just to see how we responded. And anyone that has any concerning allergic issues, it's recommended waiting for at least 30 minutes for an observation period. So there has been some concern about the immune system and COVID-19 vaccine, particularly in people with Down syndrome. And so let's talk a little bit about that. So again, people with Down syndrome were not studied with the vaccine, or other intellectual disabilities. So we can't say specifically, unfortunately, at this point for those individuals. But there were people with HIV or AIDS that were included in the study, and so they concluded that people with immunocompromised conditions can proceed with getting the vaccine. The CDC did so. There's also been some questions about autoimmunity and interferon, and particularly in people with Down syndrome. So we know that people with Down syndrome have more problems with autoimmune conditions, most of the thyroid disease, celiac disease, arthritis problems, a number of these type 1 diabetes, a number of these conditions are what are called autoimmune, where our own immune system affects a particular organ or system in our body and causes damage. And we know those problems are more common in people with Down syndrome. And so there's a question of whether that would be an issue with regards to the vaccine. And the second question often comes about is with regards to the interferon, which is part of the function of the immune system, and we know tends to be at a higher level in people with Down syndrome. So so far, there's been not a finding of increased autoimmunity in the rest of the population. That again, not people with Down syndrome or IDD who have gotten the vaccine. But of course, unfortunately, at this point, the follow-up has been short. Follow-up on average about 2 months in the study. So, potential for long-term, we don't know the answer, unfortunately. And as far as interferon, I could not find any data that suggested that was measured in anybody in the study. So we don't really have a comment that we can make on that either. One of the concerns, for example, with autoimmune conditions, with other vaccines, sometimes has been the concern about Guillain-Barré, which is a rare possible side effect to some vaccines. And Guillain-Barré is an autoimmune condition that affects the nervous system or the nerves. And the Guillain-Barré chronic inflammatory demyelinating polyneuropathy International Foundation said at this point that while there is, again, not enough data to say a definite that this is not going to be an issue, their recommendation was to proceed with follow all national and local guidelines for proceeding with the vaccine, even in someone that's had Guillain-Barré in the past. But again, if there are concerns, they recommend speaking with your own provider. So at this point, there is not a recommendation against getting the vaccine for these reasons. But again, there's a gap in the information that we have at this point. So there's still information to follow over time to see if this is going to be more of a concern. As far as vaccine distribution, here in the States, that's certainly lagging behind. I saw this morning a statistic on the news that 29% of the vaccines that are available, only 29% of the vaccines that have been distributed so far. So we're still, the federal government overseeing the centralized system to order, distribute, and track the COVID-19 vaccine, as well as state and local governments to develop the vaccination plans for the areas that are obviously still in process, and hoping they will continue to move forward and get the vaccine distributed as soon as possible. I've actually gotten asked a number of times, what are the plans? I've not heard, for example, in our practice, when we're going to have the vaccine available. And I'm just telling people, keep your ears and eyes open. Some of the residential facilities or some of the day programs, some other opportunities where there might be opportunities to get the vaccine. I'm encouraging people to get them as they can, as it becomes available in whatever situation going forward. And certainly I hope we will have them in our practice, for example, soon, and others will as well. So again, a quick summary. There is lack of data in people with Down syndrome and other intellectual disabilities, unfortunately, but that is not unusual for any vaccine, medication, or supplement that comes out. They are not these individuals are not typically included in studies pre-market before it's released. It has been well studied in the general population, albeit on a shorter, several months instead of long-term, not necessarily knowing more the long-term implications. But again, there was some concern about how quickly this vaccine was put out, and still there was a lot of people that were studied, and I don't think that is a concern. I think, from my sense, a lot of the pre-study steps were, done very quickly. So the funding and everything took place very quickly, and the study got up and rolling quickly. And so the study seems to have been well done on the short term with regards to the effectiveness of the vaccine. And again, don't want to necessarily compare apples to oranges, but our experience with the previous vaccines, other vaccines, is that the people with Down syndrome and other intellectual disabilities have not typically experienced a different pattern of side effects or had more complications from these vaccines. Now, this is a new technology, of course, as I mentioned, but at this point, or at least our previous experience has not been unfavorable, and at this point, we can hope that will be the experience with this one as well. So studies to date indicate the vaccine is a safe path to reduce symptomatic COVID-19 with the potential to save lives and aid in a more rapid return to the many aspects of our lives that have been altered, and certainly have been altered, unfortunately, to a greater extent for many people with Down syndrome and other intellectual disabilities. I certainly have been lots of questions about, the unknowns of the vaccine, the long-term effects, and we just unfortunately don't have all the answers to that at this point. But I would also caution that we don't have all the answers to the long-term effects of the virus either. We have seen a very significant problem with not only the illnesses and the complications of the vaccine, of the virus, not the vaccine, of the virus that Dr. Stridham went through earlier. But we're also learning that some of the longer-term complications that are just now becoming more aware of. So I think from a risk-benefit standpoint, we have to assess our risks and our benefits, and then make a decision with regards to the vaccine. So, as DSMIG looked at these risks and benefits, the recommendation was that the COVID-19 vaccine, again, for individuals with Down syndrome or other intellectual disabilities, be given for those who do not have a specific contraindication to the vaccine. So there's just some references, and I am going to stop and turn it over to Jessamy.
Well, thank you both so much for your expertise and for sharing the information from the Trisomy 21 Research Society survey, as well as the position statement from DSMIG. As you can imagine, we have many questions, both from before as well as on the chat. So some of these questions will be summarized because they cover a lot of the similar topics. So the first one has to do with the 10 times death rate that we continue to see. And I know, Andre, you addressed it a little bit, but continues to come up. There's a question about it's 14% of 800 people that have died with Down syndrome. If you can just kind of repeat that and, go into any more detail that you might have.
So our own comparison suggests that if you adjust for age, sex, and ethnicity, then the risk to people with Down syndrome is about 3 times for mortality. And this is based on people admitted to hospital, though, not in the community. 3 times that of the general population. The figure that people often quote, that's 10 times general population risk, is based on a data analysis of primary care data that was undertaken recently by another group in the UK. And I think the jury, what we can say is that there's certainly an increased risk for mortality in people with Down syndrome, The extent of the risk is still to be determined. I think it's less than 10 times, but it's definitely increased compared to the general population. Just to mention that we have obtained access to a similar primary care data set that was used in the other study in the UK, now with more data points because the pandemic has progressed considerably in the UK. So we have data now up to January this year, and so we'll repeat that analysis to see if we get similar figures. What I can say is what we've noted so far in the primary care data set. So this means GP records from about 10 million people in the UK, including around 8 to 10,000 people with Down syndrome. That the number of people with Down syndrome who have been diagnosed with COVID and that data set is quite small. And the number that have died is relatively small, and nobody under the age of 40 have died in the primary care data set. So I think the figure that says 10 times increased risk, you need to be careful with that, because that's based basically on older adults with Down syndrome rather than young people with Down syndrome.
Great, thank you. And then there's some questions about the safety of the vaccine and whether it should be used, or is there any priority, and what the risks are for people with Down syndrome and tree nut allergies, peanut allergies, and Alzheimer's and dementia.
Brian,
sure, I can take that one. So there is no information that suggests peanut allergies are a problem at this point. Again, I would just talk to your primary care, your private health care provider about that. But there is nothing in the CDC recommendations against people with peanut allergies getting it. But certainly, if you have anaphylactic reaction to peanuts, again, I would discuss that with your provider. Again, I think I went through some of the safety issues there. I think it's clear from the data that Dr. Stridham provided. Certainly those over 40 with Down syndrome and those with dementia, certainly we'd want to, make sure they're getting the vaccine. But I think at this point, in the United States, I don't think they're really separating out age or other health conditions. It's Down syndrome, and so that hopefully will move our folks near the top of the list, when they have Down syndrome, whether they have any other intellectual disability, whether they have any other health conditions or not at this point.
Thank you. Is there any information, or what information is there about the new coronavirus variant?
Well, I don't know. It's difficult to say. I personally, I think I've had the new variant, and so I think the UK data shows that it's more infective, so it spreads more easily, but it's not likely to be more severe in terms of affecting people more severely. But the jury is still out for that. They're also looking into whether the current vaccines will offer protection against the new variant. It looks like, at least for the UK variant, those vaccines will still be effective. There's some questions about the South African variant, but it's likely that there will be at least some cross efficacy. I don't know if you want to add to that, Brian.
No, I've heard the same thing, that there's a sense that it will cover the other variants at this point, but again, the data is limited at this time.
Right. So the vaccines are only available for people 16 or 18 and older. Is there any information about when it's going to be available for children, and what the risks are for children, since they are not going to be getting it soon?
There's just no information here. Anything in the UK, there's nothing here in the States.
No, so in the UK, the approach is to prioritize older people. So they're starting with people over age 80 in the general population, and then moving on to other risk groups. We're trying to advocate for people, for adults with Down syndrome to be included certainly if they're over age of 40, in the first tranche of getting the vaccine, because the risk is equivalent to general population over the age of 80. And then once that's been done, you would want it to move to younger age groups. So it's not that we're saying that people under 40 should not have the vaccine. It's just that, they may be a later priority, as it were. And with regards to children, as Brian has pointed out, the trials have not been done in children. So, we don't really know. But thinking about other vaccines, many other vaccines are given to children, isn't it? So, and those are safe. So perhaps eventually it would make sense to roll it out to children as well, but we'll have to see.
You talk about the order in terms of the priority for getting vaccines, and is the only thing to do is to talk to your physician in terms of whether you should get the vaccine and when you can get the vaccine, and do family members of caregivers who are family members also have any kind of priority of receiving the vaccine?
I can address what is happening here in the States so far. I mean, I think that the distribution process is lagging behind. I mean, we have a lot of vaccine that's not been distributed yet. So, I think there's a lot of unknown answers to that. And I think we still need to get this rolling more. To me, it makes perfect sense to immunize the family members as well. But again, I've not seen that as a CDC priority at this time. Any difference in the UK?
No. They are trying to prioritize people living in care settings and also people providing support to people living in care. So they would be in the sort of the higher priority list, but not as far as I know, family members.
Yeah. The people I know that have gotten it so far with Down syndrome and other intellectual disabilities do live in residential settings, and the care providers there, as Dr. Strider mentioned, are also being offered the vaccine. But in homes, I'm not aware that that's happening yet, in family homes.
There's some questions about testing positive after the 14-day quarantine. Is that common? Are they still contagious? There's one question about someone's caregiver who's been in quarantine for 14 days still has tested positive for COVID. Are they still contagious?
Mm-hmm. Do you want me to take that?
Mm-hmm.
Sure. So what the CDC is recommending is that anyone that is mild to moderately ill, even though you will a very strong chance you will test positive beyond 10 days if you've had the virus, you're not considered infectious at that point. Some people that are severely ill, they recommend 20 to 21 days. So if you're, and those people would be typically hospitalized. So even if you're test positive 2 weeks, 3 weeks later, that's not unusual. And generally it's recommended not to keep testing them because that is so common, but they're not felt to be infectious.
Are there things that we can do or any medications we can take to counter any side effects before getting the vaccine, like Advil or Tylenol?
I can talk about that. So yes, certainly that may help with the fever or sore arms or whatnot. There is some theoretical concern that blunting fever with a vaccine may in effect reduce the effectiveness of the vaccine. I would say that's not well studied. But so if you don't need it, don't take it. If you need it, take it. It's not unreasonable. But I wouldn't just take it, just take it personally.
There's some questions about, is it safe to return to school or work before getting the vaccine? And then on top, consistent with that, there's questions about how effective is the first dose, and then how long do you have to wait after the second dose?
So what the studies found is that about 50% there's about 50% effective after the first dose. And then after the second dose, about 2 weeks after the second dose, we're up to about 95%. So certainly not as much with the first one as with the second one. As far as returning to work and school, it's recommended for all of us until we have a large percentage of the population that's immune, that we all continue to wear our masks and wash our hands and physically distance. So returning to work is really an individual decision based on your risks. And I've throughout the whole thing, I've talked to individuals with Down syndrome and their families, and what is the individual's personal risk? If it's a 45-year-old or 50-year-old with dementia and lung problems, that's probably something that, they're certainly at more high risk based on the data that Dr. Stryden presented. If they're a 22-year-old with no risk factors and with good ability to wash their hands, wear a mask, and physically distance, that would certainly be much less of a concern. I certainly do have families in our practice that are going to wait until they've been fully vaccinated, and I don't think that's unreasonable. Really, some of that's just sort of like investing, depending on what your risk aversion is, how much risk you're willing to take versus what the benefit of going there. And the other thing I think is, who do you live with? If you brought it home, what's the risk of the individuals that you live with if you brought the virus home? So those are all things that really are very personal, your own personal story that you have to kind of sort out for each individual. But again, even after I just reiterate again, I think it's very important that after you get the vaccine, it's probably going to be at least late summer, early fall into fall before there's enough people that are immunized and enough immunity across the population that we can begin to lessen some of the other things that are necessary to keep this at bay.
Follow up on that question is, what are your thoughts specifically on the low risk population receiving the vaccine versus acquiring natural herd immunity, given the vaccine's potential risk, side effects?
So if as I look at what has been said and I look at the numbers, if we did nothing other than depend on natural herd immunity, at least in the United States, and this is just an estimate, we would probably have about 5.5 million people die, as particularly the higher risk people. So I think that, unfortunately, natural herd immunity, when, about 2% of the people on average will die from this, that comes at a great cost. And it's not only just the deaths, it's also what are the long-term implications of people that have had COVID? We know already that there are some heart conditions, there may be some neurological conditions, there may be some vascular conditions that people are going to be left with the rest of their lives that had COVID. And so, yes, natural herd immunity is an entity, but it comes at a very large cost.
I would strongly agree with that. I think that when herd immunity was mentioned initially, it was not appreciated what the risk may be to certain groups within our communities. And so it does not account for, the specific risk to vulnerable people. And from that point of view, I think it's a no-go. But what of course, what is happening at the moment is to try and prioritize certain groups, and particularly age groups and so on. And so it's sort of a calculated risk, I think, to try and protect the most vulnerable first, before you get to other people who are less vulnerable.
And there has been some discussion about whether we should be giving the vaccine to only those initially who have not had COVID-19 infection. And there's probably some sense to that, but at least here in the States, that has not been the decision. So they are not delineating between people that have or have not had COVID to date. Are some of the people that have had COVID already immune, at least temporarily? And, could we not give them the vaccine in the first wave? We don't know the answer to that question. And here in the States, that decision's been made not to do that. Not to delineate. And the other thing is there's been some discussion about whether we should give a smaller dose or maybe just one vaccine so that more people get it. And again, those are options that have not been studied. And at this point in the United States, those are not the options that are that's not being selected as the choice.
We're being told there's no concern for DNA mutations with the mRNA vaccine, yet the human trial participants are being told to avoid pregnancy for a duration after receiving the vaccine. So how do you know there's no concern if we aren't looking for issues by avoiding pregnancy? And how do you know there's no concern specifically for people with Down syndrome?
So this does not go into the DNA. So that's, this is a separate entity. So there is not a concern about that. And I understand that the people in the study were, people who are pregnant may not have been able to participate in the study, but the American College of Obstetrics and Gynecology has come out with their position statement is that pregnant women should get the vaccine at this point. So, again, there is no question there is unknown. But the knowns we have, the 365,000 people dead, I think that this is we are having to make some risk benefit decisions, and certainly you're going to have to make some of them individually. But from an overall standpoint, this is a pandemic, and the best knowledge we have that it makes sense to go ahead and move forward with the information we have at this time.
And just to add to that, the requirement to avoid pregnancy when trialing a new medication is not specific to vaccines. It's all new medications. It's a sort of a general rule that we follow in clinical trials, which creates problems, of course, because then you don't know what the potential effects are when people do get pregnant. But it's just one of the sort of the general rules that they follow to keep trials very, very safe.
Okay, we're running out of time, so I'll ask a few more questions. We might just go a few minutes long. So there's some questions about the CDC adding Down syndrome to the list of conditions that increase risk for severe illness. I don't know if you can address that.
I mean, I think go ahead. Based on Andre's study, I think we'd certainly support that.
Yeah, I agree. I think that it's something that flows from the study that we've done and other people have done, is that it shows that adults with Down syndrome in particular are at higher risk, and so should be offered additional safeguards. With regards to children and young people, there was a lot of discussion when we presented it to stakeholders, and there is a concern, of course, about balancing any kind of risk against quality of life issues and continuing to engage in physical activity, for example, and education and so on. So, so the risk-benefit ratio may be slightly different in younger people, but certainly we would say in those over age 40, we would support the idea that additional safeguards is required.
Okay. Can you talk about what is being done to educate emergency room physicians as well as general practitioners about people with Down syndrome who may get COVID and how to treat them properly?
Any comment about, I can share what we do here, but any comment about from the UK?
Well, I suppose all we can say is that we try and make sure that any information that we have through the surveys and so on are disseminated or made available as soon as possible. So we've created infographics that's available on our website. We do talks like this, which is open to carers as well as clinicians. We've also done specific talks with the Down syndrome medical interest group in the UK, and I'm sure, Brian, you've done similar ones to the medical interest group in the US. And we also try and make sure that we escalate any information to the powers that be, as it were. In the UK, we're in direct communication with the NHS senior management, for example, about risk to people with Down syndrome.
Okay.
Yeah, I would say similarly here, we're sharing the information. I would encourage, presumably there's a lot of families on this webinar. I would encourage you to take a look at the Down syndrome medical interest group site, the T21 site, and then share that with your with your local healthcare provider. You know, we recently published the healthcare guidelines here in the States. And one of the things I always say is that the beauty of the Down syndrome community is that the families grab onto this information and share it with the providers. And that's, in this case, you're going to need to do the same as well. Certainly, I talk to the ER on a near daily basis about lots of things. And so we've had a lot of opportunity to interact with our emergency room. But, you know, nationwide, you guys are also going to have to take, you know, the bull by the horns to some degree and share information that you find.
Okay, this question looks like it's from a physician. It says, some people have asked me about sample size of individuals with Down syndrome in the study. Can you explain whether or not this is a large enough sample to make any recommendations or claims for people who do not understand statistics?
I think the answer is that the sample size was 0, to the best of my knowledge. Do you know anything different, Andre, with regards to the number of people?
I mean, for the vaccination studies?
Right.
Yeah. For people with Down syndrome, I'm not sure that they have been included, yes.
At all. So the answer would be no, I'm not comfortable with that at all from a strictly scientific standpoint, but then I would never prescribe anything or give any immunization, because almost nothing that I prescribe on a daily basis has been specifically studied in people with Down syndrome. And so, you know, we are left to take data from the rest of the population and apply it to our patients and watch closely and see what happens. And I think we're left with that in this situation as well. But that is not different in this situation than it is in anything I've done in the last 30 years treating people with Down syndrome.
Mm.
And Andre, can you talk about that from a research side? Is it, I mean, the numbers are not large.
So from our survey, actually, the numbers are quite large now, as I said, more than 1,000 people. So we can be quite confident about things like how COVID-19 presents in people with Down syndrome, perhaps also fairly confident in the overall risk. When it comes to more rarer sort of health co-occurring conditions and what the risk associated with that might be in particular individuals, then we quickly run into problems in terms of sample size still. So we may not be able to confidently say, for example, about celiac disease, what the additional risk is if somebody with Down syndrome and celiac disease were to get COVID-19. But overall, I think, you know, we've done quite a comprehensive survey and have the best, largest data set. With regards to vaccination and the specific risk, so the next step for us at the survey in T21RS that Brian and I are working on will be to focus more on getting information on any potential side effect profiles in people with Down syndrome. So we will be trying to monitor that. The other concern that we have is that more than side effects is that people with Down syndrome may not mount the same sort of antibody kind of response to the vaccine and may actually need boosters. So may need more vaccinations rather than just 1 or 2, may actually need 3, but we're not sure about that. And so that may be another area to look into in terms of research to try and measure the antibody response. And so we're thinking about how that might be done as the vaccinations are rolled out.
Okay. Well, these slides, is this information available in other languages?
So the infographics that we developed for Trisomy 21 has been translated into several other languages: Spanish, Italian, French, German, Chinese, and some of the Indian languages. So that's available on our website. And I think you're going to make our slides available as well on your website. Is that right? Yeah.
Yes. So there's some questions about reinfection rates. If they've already had COVID, how long is the immunity, which I think you said you don't know. You know, will they catch it again? How likely is it going to catch it again? And any information about the effectiveness for the vaccine, how long before they wait to get the vaccine if they've already had it?
I think those questions are very difficult to answer. Brian, do you have any ideas? I mean, I guess we could just say what we know about other similar sort of viruses, including the flu virus. Of course, the virus may change over time, and that's why you need regular flu immunizations if you're vulnerable. And so it may be similar to with COVID-19, but we just don't know the answer to that. Brian, do you have any
No,
idea?
we really, some approaches have been to wait 90 days after ill. I think some of that was more in the sense that, we're somewhat confident that people have immunity for 90 days. Again, that's not studied in people with Down syndrome, but from the rest of the population. And so, maybe prioritize those that have not had the virus in the last 90 days more from a public health standpoint rather than avoiding the vaccine standpoint. I can tell you our healthcare system is just asking that you not get the vaccine for about 10 to 14 days after you've been ill. And that's really more from a standpoint of you should be staying home anyway. So we don't want you coming to the hospital and getting your vaccine and giving the rest of the people around you the virus. So I think, there's a lot of different approaches, and I don't think there's a solid answer. I think if you're ill, running a fever, already ill, just like any other vaccine, you should not get it at this time. And I think certainly waiting until your isolation period is over, just from a standpoint of not sharing COVID with someone else that you're going to be sitting next to in line for the virus or the vaccine, also makes sense. But as Dr. Stridham said, there is just no data to tell us otherwise anything else.
Okay. We'll do one last question and then give you guys an opportunity to add any closing remarks. If someone gets the vaccine, are they still contagious, or could they be a carrier and pass the virus to others?
Well, I can tell you what the CDC is saying is that the studies indicate that what the vaccine is doing for us at this point is preventing us from getting seriously ill. There's not clear indication that it actually prevents you from catching the virus. And so in theory, you could get the vaccine, get the virus, even though you've had both shots and you're 95% chance of successful treatment. But you could still get the virus, not be ill or be minimally ill, and then pass it along, unfortunately. So that it does not solve that problem, unfortunately. And that's part of the reason that we're all going to still need to wear masks and wash our hands and do all those other things for the next several months as more and more people get immune, so that, if a large population, 70–80% of the population is immune, even though if I got sick, it's less likely that I'm going to get someone else seriously ill because they've already developed immunity. It won't make it zero, but it'll significantly reduce that chance.
I don't have much else to add other than to say that we do think that there is much to be gained from vaccination programs for people with Down syndrome. And as I mentioned already in the T21RS, the Research Society will be trying to monitor the effect of rolling out the vaccine, particularly with regards to side effects and potential side effects, as well as perhaps monitoring the antibody response as well, if we can. And we will try and make that information available as soon as we have it.
Yeah, I would just say, I understand the concern of the unknown with the virus. I mean, with the vaccine. I understand people's concern about the unknown. And I know that's unsettling. Yes, it would be wonderful if, this vaccine had been studied for 5 years and included people with Down syndrome. But unfortunately, we don't have 5 years. And we're in the middle of a pandemic where unfortunately many people are dying and getting very ill. And so the best knowledge we have that this makes sense, albeit people with Down syndrome or other intellectual disabilities were not included. And again, I just, there are so many people that have died, and there's so much unknown about the long-term effects of the infection, the viral infection. That we just got to kind of weigh the pluses and minuses and make a personal decision. I can tell you my own personal decision. I'm getting my second vaccine at 9 o'clock this evening. I'm a go for my patients. I'm certainly encouraging them to that I don't see any reason to do anything different than what the CDC is recommending for all of us at this point.
Great. Well, I'd really like to thank everyone for joining us. We've had over 900 people join us for this webinar. It is being recorded and will be posted to our website. And this is one of the webinars that is part of the Matthew Foundation's COVID webinar series. So we'd like to thank you for your time, and like to thank Dr. Chacoin and Professor Stryden for all the work that you guys are both doing at DISMIC and Trisomy 21 Research Society. And I'd like to now take the opportunity just to say goodbye, stay safe, stay healthy, and we hope to see you on our next webinar.